Good afternoon, all. I'm Senior from Palliative. I'm requesting all participants to keep their videos on and mute from your end. Please don't unmute while faculty or the facilitator or someone is.
You are not audible.
Hello. Am I
No,
audible?
not yet audible.
Am I audible now?
Yes.
Still not audible.
May we know who was telling that? Can some participants please confirm those who are able to hear our audio? Raise their hand. Okay, thank you, Sister Vela, for confirming that. A couple of hands were okay. Thank you, Sister Anju. So I believe it is audible.
Can we rejoin the meeting?
You check your
Can't hear
camera.
you.
Madam Moderator, I'm speaking.
ये वाली जगह ना इसको ये मतलब अभी ये हम लोग जो बोल रहे हैं सुनाई दे रहा है जब ये लाल लाइन आ जाएगी इसी को मतलब हम म्यूट हो गए तो उनकी आवाज नहीं आ रही है अब तक
We have a few participants without their videos on. I'm requesting all to keep your videos on throughout the session. As I have already informed in the WhatsApp group, your attendance will only be counted if you are attending the whole sessions with video on. And I'm requesting Sushma ma'am to keep your audio off. Please be muted. Sangeeta ma'am and Bashira ma'am and Srijana Sharma, Adam Sherpa, kindly turn on your videos. Sushma ma'am, kindly take the audio from your end and your connectivity. I don't think that the problem is from our end. Ranjita, can you hear me? Yes, so I'm audible. So we have only 10 minutes left with us. Before moving on to the session, I have to let you know a few things that I'm going to share my screen. Can anyone please confirm if my screen is visible or not?
Yes, ma'am, it's visible.
Thank you. So this is our foundation course in palliative nursing 13. In short form, we will call it as FCPN. So we this is our ECHO season 115 and FCPN 13. The number of sessions we will be conducting is 18. And a program inclusions prescribed syllabus for nurses. Practice in palliative care. We will be having a pre-test questionnaire. I think all of you have gone through the pre-test questionnaire. And all of you are supposed to submit a case presentation. That case presentation, we will be having more than 40 participants, and the faculty panel will be deciding which cases should be presented online in the session. And we'll be having 6 assignments in total. One by one, we will release the assignments, and you can complete it. All the learning materials for this assignments and all things will be shared to your IACO account, IACO.org. Using your user ID, mail ID or password, you can log into your IACO account, and you can collect all the learning materials, download it, keep it, and you can read, you can go through it again. And we will be sharing the video links of each session, each of the sessions, we will be sharing the video links to your IACO account also. So for certification eligibility, we have some mandatory clauses, that is a minimum of 80% of attendance in person, to ensure that your video should be on. That we cannot understand if you are online or offline, if you have turned off your video. So we ensure that you should ensure that your video is on and you are visible to the host side or the hub side. And the completion of 6 assignments with a minimum of 70% of mark for each. You have to score at least 70% mark for each assignment. And if you fail for one assignment, you will have the option to resubmit it. After the completion of the first set of assignments, you can resubmit it again, and we will go for the evaluation, and we will let you know the results then. And submission of one patient story or case presentation in time. Like if you are choosing the topic management of pain 1 or introduction to pain, you have to share the case. You're supposed to share the case presentation before the session. Like if we are going to have a session on 17th Thursday, you have to share your case presentation at least on Tuesday. We have shared the detailed schedule with you, and I have already uploaded the schedule in IACO also. So you can fetch the case presentation template and the PDF the syllabus and am I still not audible?
Yes, ma'am, it's audible, ma'am.
Okay, I'm requesting all to kindly check your audio devices and network, because I think I'm perfect from my end.
Yes,
So
ma'am.
please kindly go through the schedule I have shared with you. The session dates are mentioned in the schedule. The session timing will be from 3 to 4:30 p.m. So I'm requesting all to join at least 10 minutes before the session begins, as we will be having connectivity issues or something at the beginning of the beginning when you try to log in. So in order to avoid all this, I'm requesting all to join 10 minutes prior to the session. In this session only, you have to log in at 2:30. At least you have to log in at 2:50 p.m. So attending the pre-test questionnaire, I have shared the pre-test questionnaire, and I know a few of you are still to complete it. So I'm requesting all to complete the pre-test questionnaire. I will be sharing it once again in the WhatsApp group, and we'll be having a post-test and end evaluation other than these assignments. Post-test and end evaluations marks won't be counted anywhere. That is for another record purpose, and we need to know your improvement through that. And we will be having session feedbacks. We will be collecting session feedbacks after each session. We will be sharing a Google form link with you. So you have to fill it up after each session, so that we can understand how useful the session was for you, and we can improve otherwise we cannot improve ourselves. So your feedback for each session is very, very important. And how to join your sessions, I think you all should have understand that now, because IACO will be sharing separate links for each participants, automatically generated link through the LMS platform and IACO, and it will be received in the email, WhatsApp, and SMS exactly 30 minutes before the session start time. Regarding the case presentation, submitting a case is mandatory for certificate issuance at the end. And we have shared a PowerPoint format with you. You have to share it back with us with the selected topics case presentation. Each participants need to come with a patient story among the 18 enlisted session topics. I have shared the topics with you already. We will be having a case presentation from our end at the start. Today, we will be having a model case presentation for you. If you are not presently working or not having direct exposure to any patients, you can bring in any old patient story which you feel is relevant to the topic chosen by you. So that's all. And about the learning materials, I have already informed you that we will be uploading all the learning materials in the IECO platform that you can access yourself. Thank you all. So today we will be having our first class on introduction to palliative care. We have our faculty and facilitator joined us. We have our facilitator, Dr. Sridevi Warrior. She is the head of our virtual education and education team in Palliative India with a lot of years of experience in palliative care. And today our faculty is Lieutenant Ali Stella Verginia. Stella ma'am is here. Stella ma'am, welcome to the session. And I'm handing over to Sridevi ma'am for further session facilitation and faculty introduction. Please, ma'am.
Good afternoon, everyone. Am I audible? Okay. So thank you everyone for joining us for this wonderful program for nurses. We have another nurse facilitating the whole session, but currently she's attending a training program. So I'm replacing her for today's session as facilitator. As Sinia mentioned, I hope that the program pattern or the structure is familiar to you all by now. If you have any queries, please reach out to us, ask in WhatsApp group or email us, or you can call Sinia and ask if there is any doubt. And as she mentioned, it is mandatory to have attendance. It is mandatory to have case presentations from your side. And we'll keep sending reminders to switch on your videos during the session. So that is also, again, that is something that we insist. And interaction, all the sessions will be interactive sessions. So we expect interactions from you. If any of you feel any issues with language, just let us know that if you are unable to follow the language, that means the sessions will be in English. If you have any problem in following the language, just let us know. Write to us that you're unable to follow the last session, then we'll look into it. As of now, all the sessions will be delivered in English. But if you face any difficulty during the course, please reach out to us. Otherwise, we will not know what you're going through, whether you're understanding what we are delivering. So thank you so much, everyone, for joining us for this wonderful program. As Sinia mentioned, today we have Sister Stella as our faculty. Today we'll be talking about an introduction to palliative care. What exactly palliative care means to us, to come into a common ground so that we can take the discussions forward. So Sister Stella was serving in Indian Army for many years, and she joined Medical College in Kerala in 2006. And since 2007, she's working in palliative care, and she works with many organizations. She's a constant teacher to many of us. She's a national faculty for almost all training programs happening for nurses, I must say. She's received an award, International Excellence in Palliative Care Award. I know that Sister Stella doesn't like telling all these all these things about her bio, but I'm forced to tell because I'm here facilitating the session. Thank you, Sister Stella, for agreeing to be part of this program. Over to you. Can you unmute, sister?
Yeah,
I'm audible? Thank you so much, Dr. Sridevi. Nice to see you after some time. I will first share my PPT. Is the screen visible?
Yes, it is visible.
Yes, ma'am.
Okay, so in the first session, I welcome you all the participants. I think from most of the parts of India, they must have joined. How many are there, Sini? Total?
Ma'am, we have around 27 joining us.
Some joined us. Okay, so today we are going to have an overview of the palliative care. It's just to say like introduction to palliative care. And as Dr. Sridevi said, it will be in English. But of course, if you have any doubts, those who can't follow properly, I can speak in Hindi also. Okay. So you have some doubt, you can ask also. And any questions, please put it in the chat box so we can take it in the after the session. Okay. So my first question is, what is palliative care? Anybody knows about palliative care? You can just put in the chat box because you have joined for the course. So at least you must have gone through something. So just want to know what is palliative care, what you know about palliative care. Anyone? Just put it in the chat box. What do you know? Just.
Srijana, if you're talking, we can't hear you.
So there are some answers. Care that is rendered to patients with lifelong illnesses. Michael David Good. Care provided to terminally ill patients. Chetri. Okay. Any more? Care provided to terminally ill patient. Care that focuses on quality of life for those with life-limiting illness. Good. So you have some idea about what is palliative care. So we'll just see it is whether it is for the terminally ill patients or whether it is for life-threatening for the patients who are faced with life-threatening illnesses. Okay. So when we talk about palliative care, we need to know what is palliative care, who needs actually, which patients require palliative care, and how do we deliver the care, who will be benefited with that, and of course the importance and need to develop palliative care. Okay, and summary and conclusion. So it has been said that medicine is not about conquering disease and death, but about elevation of suffering, minimizing harm, and soothing the journey of man. So if you ask me, it is very true that we were just thinking about only disease and death. Always just thinking about disease and death. Somebody is falling sick, they have a disease. If they are able to be cured, well and good, otherwise they will die. Okay. But apart from that, what do they suffer, what they undergo? Not only the patient, the family also. Okay. We never go through that things. Sometimes, to say in a very simple way, sometimes it doesn't matter for us because we are bothered about the patient's problems. Okay. Giving medication and this thing, and patient is okay, fine, then discharged. Okay. And if the patient is not fine, okay, still patient is discharged. After that, nothing. Okay. So actually palliative care is not that. Okay. So what is palliative care? Palliate means elevate suffering, to lessen pain. So when I talk about pain, you may be thinking pain, maybe body pain, headache or something, somewhere in the body pain. No, not only that. Pallium means it's a cloak, a cover, to cover. So especially in northern parts of India, northeast part of India and all, winter must have slowly started. Okay. So once winter starts, We cannot just put a jacket and walk. And especially by the time it is December and January, I think you have to cover everyone, even with a monkey cap, only your eyes will be seen out, right? Okay, because it will be very cold. Bhutia is smiling. It will be very, very cold. And people like us, if we come to your place, we won't be able to tolerate it also. We have to cover everything. So it is a cover. Whole body is covered. Okay. So it is said that in the Quran, it is written, may you be wrapped in tenderness, my brother, as if in a cloak. So symptoms are clogged, means symptoms are covered with the treatment. And primarily, what we aim is on patient's comfort. Okay. So there is nothing more I can do. Most of the time, that's what we say to the patient. There is nothing more to be done. You can take the patient home. But in palliative care, there is always something I can do. Otherwise, we can do. It's not that the patient is not cured means there is nothing to be done and the patient is sent home. No. Right from that point, there are a lot of things that we need to do for the patient. So palliative care is that. So let us see what is the definition of palliative care. So clearly, I know you all must be watching the video. Just have a look. Okay. Palliative care as an approach to that improves quality of life of patients and their families. Quality of life. That is very important. Quality of life, not only for the patient, but for their families facing the problems associated with life-threatening illnesses. So it is a life-threatening illnesses through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems also, physical, psychological, social, and spiritual. So that is palliative care. So one of you have written that it's a life, end of life care. So please take that from your, this one, thoughts. No, it's not for, or not only for the end of life care. No, we started right from the diagnosis so that the patient will be there with us till his end. Okay, so the facing life-threatening illnesses. So palliative care is for all types of life-threatening illnesses. It's not only for cancer, that also it's not. For all life-threatening, maybe a paraplegia patient, quadriplegia patient, it can be a stroke patient. So remember all end-stage diseases. So not just for a life-threatening situations also, elevation of suffering is needed for all who have a curable as well as those with an incurable illness, and certainly needed for those with chronic serious illnesses. One more step if you go, that is very right. See, I have served in Indian Army, so I know it very well because the patients won't have any bystanders, no relatives at all. Once they are sick, they have to see only our face, nurse's face, 24 hours. Okay, and they used to, when we talk to communicate with the patient, they used to share all their problems. At times even they share, because now at least there are mobiles, but in my time there were no mobiles at all. Okay, people have to write letter, and a letter reaches very late, 2 weeks, 3 weeks and all. Okay, so by meantime, the patient's family and the patients now usually whatever is there, they used to share with us their problems. And most of the time, it is not the physical problem what they share. They share the psychosocial problems of not seeing their family. The family has not come to know that I am in the hospital. Okay, so don't think it's only for a curable, incurable diseases. No, it is for a curable patient. A patient just suffering from a fever, when he's all alone, he needs someone can talk to him. He wants someone to listen to him. And so palliative care, hospice care, we can say, palliative medicine, it's a specialty. Now soon palliative nursing is going to come. Again, it will become a specialty, palliative specialty, nursing specialty. Supportive care, it is throughout the illness, it is a supportive care. Terminal care, a part of the palliative care. These are the terminologies used. So if we say, actually palliative care was there since long. It is not so new, we cannot say. It was there. Okay, but the actual, that scene, otherwise the people came to know. It was during the 1960s in UK. Okay, so during the Emperor Ashoka's reign also, there was palliative care, like a hospice. There was a concept like hospice. People not well, they were put in a place and they were looked after. They were given everything over there. Okay, but actually that concept which has come, it started from 1960. So we'll come to that. So hospice care. Okay, Mary, Mother Mary Aikenhead, she's an Irish sister of charity. Okay, it was in Dublin. That was the first hospice in the context of the patient care, which was started in Dublin. Okay, but the modern hospice, first hospice in India, it is a hospice of Desbansis de Richmond in 1876. I'm not going to that detail, but this you need to know. The modern first hospice was started by Cicely Saunders in 1967. It is in St. Christopher's Hospice in London. This was the modern hospice which was started. And you need to know her about her also. Since she was a social worker. And she felt that in order to look after the patients, I need to do something. So she became a nurse. She took a nursing training. She became a nurse to look after the, to care for the patients. But again, she didn't stop over there. She became a doctor because she saw the sufferings of the patients in pain. And for her, this one, her concept is only total care. That is a total care. Because a person suffering from pain, physical problems, also suffers from psychological, social, and spiritual problems. And she's the person who said, it's not enough just to look after the physical problems of a patient. The patient needs a total care. So a total care is what? A palliative care, which is given a total care, physical, psychological, social, and spiritual care. So that is very important. So remember, Dame Cicely Saunders is the person who first started a modern hospice, and it is called as St. Christopher's Hospice in London. One second. Oh. Okay. Now, if you see this on the first one, you have a look, this one. See, most of the time in the old concept, what it was full curative care. And when the patient was going towards a death, they used to give palliative care. That is in the terminal stage, they used to give palliative care. Okay, but what about this concept? Just have a look on this concept. This is the curative care and this is the supportive care called as the palliative care. So right from the diagnosis, the patient has to be there with us. See, here the patient is being diagnosed with, just one second. Okay. See, right from the diagnosis, if the patient is there with us, this side is the curative care. So it is in a broader area. Patient is in curative treatment. But by the time it slowly goes, you can see it is narrowed here. Right? Now you see here what happens. See, patient, at the diagnosis, patient is given palliative care also. But in a very small way. But as the disease progresses here the palliative care also, supportive care also progresses. You see? So this part is full palliative care. And here the patient dies, means if patient is under terminal care, after that the patient dies, and still we give palliative care, that is bereavement care. So we are not leaving the patient's family after the patient's death. Mostly what happens in the hospital, once the patient is dead, pack up and send. That's all, finished. Now what is going to happen? What is going to happen in their house and all, we don't know. Okay. But in palliative care, what we say, we have to be there with the patient while the patient is dying also. And after that also, we need to give them a bereavement support for the family. And that is very important. So if you see this one, you can have, see, this is a place when the patient is not keeping well. This is a preventive time. Okay, preventive care. But here the patient is diagnosed with some problem, some disease. We'll have curative and restorative treatments for the patient. But maybe with the prognosis of the disease, this will narrow. And here the patient needs a palliative care right from beginning. Now, when we talk about palliative care, with the curative care, many times in here also, when the patient is taking some radiation, chemotherapy, patient will have other symptoms also. Sometimes constipation, vomiting, pain, patient may will have. Okay, so the patient is then sent to palliative care. So right from the beginning, we get the patient over here. Okay, so his symptoms are controlled, and with that, remember, we communicate with the patients and we'll come to know what are the patient's psychosocial and spiritual problems, even financial problems also. So right from beginning, when the patient is with us, as it goes on, end of life care, also the patient will be there. And when the patient is actively dying, also patient is there with us. So death occurs, and after that we give a bereavement care, because already you know the patient, you know the family. So your relationship will be very good. And you are preparing the patient and the family to face what is going to happen after some time. Okay, so here palliative care focuses on quality of life, improving the quality of life of the patient and the family. That is important. See, Dame Cicely Saunders said, you mattered because you are you, right? You mattered to the last moment of your life. And we will do all that we can, not only to help you die peacefully, but to live until you die. Very nice, na, these words? Just that first word, it's a you mattered because you are you, and you mattered till the last moment of your life. See, once you're born into this world, you have to die one day. But we need to die in a dignified way. And that is very important. How much care we give when we are born. So that much care we have to give to a person who is dying also. And that is very important. You and me, we all need this. So the good quality palliative care can be defined as the care which I would be happy to have given to a member of my own family if he or she was dying, or to receive myself when my time comes. Today, you all, once you go back, just think about this. Whether I'm able to give a good quality of life, good death to my family, and which I also need. That is very important. So the whole person approach should be symptom control, psychological support, and of course, disease management also should be there. And it is always a multidisciplinary team should be there. Only one nurse cannot do everything. We need doctors, nurses, social workers, physiotherapists, many people we need. At times, other specialty doctors also we need. You see this person. This was a photo, long back taken photo. I think here only in, when the palliative care was first started by Dr. Rajgopal and all. You see, what can you think about this photo, this picture? Can anyone just put 2-3 words response in the chat? What do you think after seeing this photo? What do you think about it? Somebody has put something. Let me have a look. Stressed. Okay. Any other thing?
Sangeeta has said that severe pain.
Hmm. Yeah, very right. Severe pain. Suffering. Very good. Can't sleep. Yeah, he is in pain. Yeah, see. This one picture itself is showing you many things. He's not able to sleep, he's in pain, he is suffering, mentally, physically, spiritually also, socially also. Okay. So here, if you focus only on his pain, that is not enough. There are a lot of other things. As you said, the patient is stressed. Of what? He may be having some psychological problem, which we need to communicate with him so that we can take out from him what is his psychological problem, what is his social problem. So this is a patient with CS stomach, operated 2 years ago, with severe pain, vomiting and sleeplessness. Sole bread earner of the family, wife and 3 children is having. So he says, I should not have taken to alcohol. Am I dying? Who will look after my family? Can't you do something to save me? So what are his problems? So he has a lot of problems. See, he's having pain, vomiting, sleeplessness. Now sleeplessness, why? He has some psychology of him. He himself is thinking that because I had taken alcohol, I am suffering this problem. Am I dying? And if I die, what will happen to my family? He's asking someone, can someone help me out with this? So it's not only physical pain, but he's having other psychosocial, spiritual pain also, which needs to be addressed by the healthcare providers. That is very important. So here, is it just a physical pain they suffer from? No, physical pain, vomiting, lack of sleep. Now psychologically, if you take fear and anxiety, uncertainty, guilt. What was the guilt? I have consumed alcohol since so many years and that's why I'm suffering now. So that is a guilt he is having. So that fear is there inside, that anxiety. If something happens, who will look after my family? Social, if you take 2 weeks to go for work, he cannot go for work now. He will lose his job. He will lose his role in his family. Spiritual, why did God do this to me? Am I punished? Financial problem also will be there for the patient because he's only breadwinner. Now from where he's going to get for the treatment to look after his family? So that is a total suffering which affects the quality of life of the patient and family. It's not only the patient and the family. So we need to address all the problems, not only for the patient, but for the family also. So we need to communicate with the patient and as well as with the family. So in palliative care, when we talk about palliative care practice needs attitude, knowledge, and skill. So when we talk about attitude, our heart. When we talk about knowledge, it's our head, brain, and our hands. Because this all gets connected to each other. So that is very important. See, I won't add only in palliative care. If you are in nursing, you need all these 3 things. You should have an attitude to, you should have knowledge and you should have the skills. Every nurse needs these three things, what is being said. So concerns in a chronic illness when we take physical, emotional, social, and spiritual. So we need to address all these things for a patient. Okay. So the worst thing to say to a patient is there is nothing more we can do for you. You can take him home now. See, a patient is having this problem. Okay. And you are finally from the hospital telling, okay, everything is been done. Now nothing can be done because the disease is progressed. But no. To cure sometimes, to relieve often, and to comfort always. If all the disease cannot be cured. We can relieve sometimes their problems. And we can give comfort always, and that is important. So when physical symptom control, when we talk, let it be for anything, a detailed assessment is very important. So in palliative care, we take a detailed assessment of all the problems of the patient. So we explain to the patient, that is communication we do, treatment based on what the patient is having problems, regular reviews, and the continuity of the care. Symptoms are managed. In psychosocial care, when we come, the psychological issues, we address the patient's psychological issues, so that we need to communicate first to the patient. Just listen to the patient, what the patient is saying. What are his problems he is saying? Listen to the patient. He may be angry, guilt feelings, denial, sadness, fear of the death, anxiety, inability to work, financial losses, altered body image. This has changed. His body is already changed. That image has changed. You saw that. One big wound is there. So it has changed. Spiritual distress the patient will be having. So how do we address psychological distress? Psychological distress is addressed by just listening with our 2 ears. Remember, we have only one mouth, one tongue, and we have 2 ears. So always listen. Don't sit and talk, whatever you feel you are talking. No, listen to the patient. Let them come out with everything. And once they come to know that you are listening to them, they will pour out everything to you. It may take time. I always tell, whenever I take a session, I always tell, no patients, all the patients know that you're not going to give even one rupee to them. Okay. And even if the patients say, I have not taken food also, maybe we won't be giving them anything. Okay. But at least there is something that listening. We are asking, you had food? If the patient says no, we can ask why you didn't have food. At least we can talk to the patient. We can listen to them. What is their problems? So give time to that. So again, that is palliative care. Disease should be managed. So I'm not going to that. Okay. Whatever the problems the patient is having, that appropriate conditions, whatever the patient's problem is there, that has to be managed. Okay, it is not that patient is in the palliative care, we are not going to send the patient back. Many patients come during the chemotherapy, radiotherapy. Some patients who are still, like we'll talk the other diseases, like patient is a stroke patient. Okay, stroke patient, one side paralyzed. Patient needs everything, right? We need to change his catheter maybe. He is in a RILES 2, we need to give that care. Okay, physiotherapy, we need to give physiotherapy to the patient. Okay, so it is not that the patient is having a life-threatening illness and we won't do any disease management, nothing like that. Okay, it goes side by side. See, it's a patient, a rectum patient, repeated ascites patient is having, and this has to be the ascites, water has to be removed. We need to do the tapping. How long the patient will come to the hospital? It's very difficult. Can you see? Big stomach. It's very difficult. We need to go to the patient's home and relieve that. Patient cannot come to the hospital every now and then. That is very difficult for the patient and the family. So palliative care is total care. provides relief from pain and other symptoms, affirms life, regards dying as a normal process that should go inside. Yeah, dying is a very normal process. You are born, you have to die. Yeah, we all are scared also, okay, including me. Okay, but still I do think always how I will die, when I will die, what will happen to me before death. I do think about these things, but I have to die one day because it's a normal process. It intends neither to hasten or postpone death. In a palliative care, we don't postpone death or we don't hasten also death. When it has come, it will come. And integrates the psychological, social, and spiritual aspects of the patient's care. And that is important. Offers support system to help patients and the family. Never leave the family. Okay, always family should be with us. And it uses a team approach. A team approach is very important, as I said, will enhance quality of life. So our focus is on the quality of life. Okay, and is applicable early in the course of illness with other therapies that are intended to prolong life, and includes those investigations needed to better understand and manage distressing clinical complications. It is not unnecessary investigation, unnecessary medication is nothing being given to in the palliative care. What is appropriate that minute or that second, that is only is done. Just have a look. In acutely ill patient, what happens? They come to the hospital, doctor sees the patient, and they are back normal. After maybe with a fever, a patient comes, after 3-4 days, patient is normal. But in a chronically ill patient, you see, what happens to a patient who needs a regular attention, like a catheter is there for the patient, urinary indwelling catheter is there, Riles tube is there. And once you discharge the patient, what will happen to the patient? Who is going to change this? Who is going to give the care to the patient? Big wound is there. Who is going to take care? That is very important. So how is palliative approach different? Palliative approach is different when we talk, because we see the person as a whole. That is a total care. Respect the patient's wishes. If suppose a patient says, I have come across many patients saying, we don't want chemotherapy. We don't want it. Everything is done now. Nothing. Just you relieve my pain. I want to sleep comfortably. That is enough. So respect the patient wishes. Accept patient's refusal of treatment also. That is very important. Patient says no means no, but you have to give the options and you have to tell them if this is not be done, what? Okay, that we have to talk. It's not that patient says no means and you walked off. No. Drug doses modified to maximize efficiency. Patient is having pain. We need to modify the drugs, the doses, so that he'll be comfortable. Okay. Here, you see, comfort. The patient had severe pain due to this. So slowly the patient's oral morphine was started, and without feeding tube till the end, the patient has gone very well. Because this patient autonomy was respected, because patient said he doesn't want a Riles tube. With oral morphine, his pain was controlled and he left this world peacefully. So when should palliative care begin? As I said before itself, I told right from the diagnosis, during the course of the treatment. Of course, some patients do come to us at the terminal phase also. Okay, so that time we cannot, it's not that we will be saying to that patient, no, we cannot look after you, we have come at the end stage. No, that also we cannot do. If the patient comes to us right from the diagnosis, well and good. But if the patient is coming after starting the treatment with some problems, good. Maybe towards the end of the life. And of course, sometimes supportive care throughout the illness. So palliative care is not just terminal care. Okay. See, it was said this patient, he was suffering and he said, please kill me if you can't relieve my pain. And you see he's smiling. His pain was relieved. And again, he started to do his job. Who can benefit from palliative care? You can see here, cancer, HIV patient, muscular dystrophy, chronic diseases. Okay, chronic disease, even end-stage diseases, lung diseases, heart disease and all. Okay, age-related problems, geriatric patients. Okay, patients and families in the intensive care units. All many patients die in the intensive care units. Being in the ventilator for days together, weeks together. Why? I would like to share one thing. I came across one of my students, I should say. She told me about her because when I was taking a communication session, after taking the communication session, especially breaking bad news and the rest of the things, she started crying. So after the session, I just went and spoke to her. So that time I came to know she lost her child, 4 years old daughter, just about 40 days before. So well, you know what she shared, I felt maybe because I was talking about the breaking bad news and all, maybe she started crying hearing that, must have thought of her daughter. But you know what happened? She told me, she said her daughter was a physically challenged child, okay, cerebral palsy. And she used to get every now and then convulsions. So one day she had a very bad convulsion. She was taken to the hospital and she was put in, she was taken to the ICU. Okay. And this mother, being a very village lady, she doesn't know much about the hospitals and the terminology especially. Okay. Okay. So every day she used to ask the doctor. So doctor will say, yeah, fine, still going like that. So after 15 days, she told her husband, say, since the day I came, I can hear only this. I would like to see my daughter. So she told the doctor. So doctor said, okay, we will see that you can see. She went into the ICU and she can see so many ventilators over there. And she was just trying to figure out where is my daughter. And finally, she made the daughter and she got shocked. She said, here, everywhere, tubings I could see. I was shocked. I was not knowing what is happening over here. So she just went and asked doctor, why the child is put in a lot of tubings and all. What is this? She asked. So doctor said, your child is in ventilator. She said, ventilator? What is this? I can't understand. So he said, with the support of this ventilator only, your child is breathing and your child is alive, it seems. And you know what she told me? She said, immediately she told to the doctor, I don't want my child to be alive with a machine. Please take it off. And you know what she told me? She said, ma'am, if I knew that ventilator means it's a machine which is supporting her life, the first day itself, I could have told the doctor not to put her on that. Let her go peacefully. Now, how much my child must have suffered. And you know, the next what she said, everyone should know about palliative care. Because in palliative care, we do say, don't talk in medical terms to the patient and the family, because they can't understand your medical terms. You need to talk in their language so that they understand. This I'll never forget in my life. So remember, we need to explain to them exactly what is it. Okay, so where palliative care where we can begin. At home, we can give palliative care. In the hospital, we can give palliative. In hospice, we can give palliative care. And remember one thing, in the hospital, in your wards, you can give palliative care. It is not that only palliative care can be given only in palliative care. No. In your hospital itself, in your ward, you can give palliative care to the patient. Because all the patient doesn't need everything. Some patients may need your time to communicate with them. They need some psychosocial support and some spiritual support. So provide palliative care in the place of their choice also. That is another thing. So there are a lot of, this is about the, neighborhood network. Okay, so community, local community. I won't go into detail about this. We need the local community to support us in palliative care because alone we cannot do. Local community, why? Local community knows about the networking in that area very well. Okay. See, I am here in this place, so I know my place very well. But if I come to your place, I won't be knowing about your community. Okay. So local community support is very important, whom we call as volunteers. So volunteers has to be trained so that they can support the nurses and doctors. So a network of trained volunteers we need. And they should be trained also. That is very important so that they can support the institution and organization. Here, if you talk in even primary healthcare centers, we have volunteers who are supporting the primary healthcare providers. Okay, I'm not going to this. So goal of the palliative is to bring back that smile, improving the quality of life of the patient and family, so that when the patient leaves this world, he goes peacefully, and the family also remembers him peacefully and happily. It's not that after the patient's death, they are saying he suffered a lot. We can still remember, we are remembering how much he suffered. He was rolling with pain. He couldn't sleep. We also did not sleep, and all that things. No, they should, that in their memory, it should be sweet memory of the person who has left their life from their life. It should not be a bad memory. And whatever we do to the patient and the family, it should be a sweet memory, not a bad memory. Tomorrow that patient's family remembers, as soon as for something they have seen you, they remember, oh my God, this sister, this doctor, how much they gave this one, suffering for my patient. We need to give them a peaceful, dignified death and be with them. Give hope, appropriate to the stage of the disease only, give hope. Hope of cure, not for everything. Hope of prolonging life, hope for relief of symptoms, hope for peaceful death. Patient should be as comfortable as possible till the last breath. That is important. Putting a big mask on the face, patient is doing like this. And we see, we are looking at that. And if the patient dies, the family will say that sister came and put a big mask and he was suffering like anything, was rolling on the bed. Actually, just find out whether he needs an oxygen or not. Yeah, after in the hospital, we do this, thinking that at least people who are standing and looking at now, they will say, oh, they have put an oxygen. But the saturation is still below 50 only, after you have given full oxygen. Why? Once everything is gone, I spoke to one patient's son. He said, my father is in oxygen therapy. Still oxygen is going, and this one, saturation is still low only. Why? It has not improved. And you know what is the case? Lung cancer. And towards the prognosis is very bad. Patient has almost reached to that end. Okay, I need to explain to him how we take how the respiration happens. Oxygen intake means our taking air, giving carbon dioxide, everything, blah, 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 alveoli, lung, this one, that one, everything. I spoke to him. Then he said, now I understood why oxygen is not making any difference for him. He said that I will take him home without oxygen itself, because he's more comfortable without that oxygen mask. Yeah, if you feel that really the patient needs oxygen, put a prong now. That will be more comfortable. At least you will be able to see everyone. Although the world is full of suffering, it is full also of overcoming of it. It is there. People are there still in this world who adds up good things to others' life. So I'm not going to this, just more than 1 million new cancer patients are there in India, 80% in advanced stage. And if you talk about the other NCDs, other non-communicable disease patients also are there. So it is very important that in the developing country also we need palliative care. So importance of developing palliative care throughout globally is very important, and especially if we talk in India. So education is very important. Drug availability is important. It's not only about morphine, rest of the drugs I'm talking. Okay, and one more thing is very important is education and integrating palliative care into the medicine and in the nursing. Of course, in the medicine and nursing, a little bit has come out, especially in BSc nursing in the second year, part 20. Yes?
I think that was a background disturbance from the party.
So, okay, sorry. Okay. So training is very important. We need to integrate palliative care in our undergraduate education. Okay. And of course, it will take time to come still. But whoever has already passed out, who is working now, they need to be trained. And like you people are getting trained in palliative care, that is very important. Okay, so this and all I'm not going because you will have a pain session about the WHO ladder and all, and these things will be taught to you. So summary is balance of science and compassion. Because palliative care addresses all aspects of suffering. It's a multidisciplinary team, focuses on quality of life, includes patients, family, and the caregivers, benefits all those with illness-related suffering, and should be available throughout the illness, and importance of developing the care in our country. Okay. So, and we have a nice presentation. I just gone through the presentation. It's a very good presentation. So we'll have the presentation and then we will have the discussion.
We can take 1 or 2 questions now.
Yeah,
if you have
sure.
any. Just a few questions for a few minutes. So anyone who's already working in palliative care in this group? Or everyone is new to this topic and the setting? And do you have any questions for Sister Stella before we move on to case presentation? Either you can unmute or you can type it in the chat.
You people don't have any doubts?
That's what I was thinking.
At least
Any
you can you please say if there is any palliative care in your area, if you are not working also, any palliative care in your area, in your country or in your place? Karma, Lamu, Sherpa. Do you have a palliative care there? Yes or no? No. Okay. Gureng? Supriya Gureng. You're from Nepal. Do you have a palliative care?
No, ma'am.
No. Yeah. Okay. No, this is one Zangung Bhutia.
Yes, ma'am. I'm from Sikkim.
Achha, Sikkim. Oh, Sikkim has a palliative care. Very right. When do you have palliative care? San.
Yes, I'm from Malaysia. Yes, we are in a palliative.
Achha, you have a palliative. Oh, Malaysian do have a palliative care. Nice.
Yeah.
Oh, Priya Jaya is from Goa. You do?
Yeah.
Yeah, Goa has a palliative care. Right?
We have a few participants from outside the country also. Like
Achha, okay.
I think Elijah, which country you are from? Can you unmute yourself?
Sanson was from Malaysia.
We're from Uganda and it's not there at the scale where I am at my level.
Okay, so he's from Uganda, Sister Stella.
Achha, Uganda. Uganda do have palliative care, right? Because Dr. Moira Long is from Uganda. She's doing a lot of palliative care over there. I don't know in which part. Sarah Fisher in US, huh? It is still here. It is still very needed even in USA. Many patients die without the benefit of palliative care. Oh.
Sarah, would you like to tell a little bit about you?
Yeah.
Like where you are working and what you're doing?
Yes, I am a nurse in the US. I worked for 10 years on a medical surgical floor and really became passionate about palliative care during that. I'm presently working with a team in Bangladesh, rural Bangladesh, because we don't have a substantial palliative care program there. So some of my colleagues are on this call as well.
Okay. Clinty Sebastian has asked a question. If the patient's relatives are unable to understand what is palliative care and unable to accept the situation, in that circumstance, what shall we do? Communication. Communication is very important. See, unable to understand what is palliative care, to my knowledge, if you sit and communicate with the patient, see, sometimes one sitting is not enough also, okay? Because they try to balance it and see, okay? That is very problem sometimes. They balance it and see, because we are saying, see, this disease is not able to be cured and the patient's treatment is limited now. He needs only supportive care and all. So there we need to explain to them properly why the treatment is not going to benefit him and what is his prognosis. Many times what happens, half of the thing only we'll talk to the patient's family, patient or patient's family. Okay, so explaining about the patient's disease and its prognosis and what will happen ahead, that is very important. And as I said, talking to their language, sit, we need to talk to them. Maybe in 1 or 2 sittings only, actually it will go inside. Then they will try to understand you and then let them take the decision. See, decision should be theirs, not ours. Autonomy is very, very important. So wait for that.
Ma'am, actually I'm Clinty.
Yeah,
I'm
Clinty.
Clinty. I had what happened is that I'm working in a small palliative care center here. So
Where, sister?
It's in Siliguri. Siliguri, and it is not.
Acha, Siliguri. Yeah, Siliguri. Okay.
So what happened is that the patient relatives, whenever we explain to the patient relatives, there are circumstances the patient is about to even die, and they have a hope that the patient would survive, and we make them understand what is ahead, they just want to take the patient from the center and take them to a higher center and put the patient into ventilator. And what happens that the patient sustain maybe for 2 or 3 days, and the patient suffer and die. So at times it is a dilemma to make them understand.
It's not only there, it happens here also. It happens all over the world, because it is like now patient wants to see more again and again. Something can be done, it happens. But if you take 10 patients, maybe out of the 2 people, they want to do it and see. Sometimes, see, if you ask for myself, even to this one, maybe at one point, maybe I will also start thinking like that. I can't say no to this, okay? But from our side, our duty is that we have to explain to them properly. And after that also, they are not convinced or they want to go for that, it is very difficult. We can't do anything. Okay, because palliative also say autonomy. Autonomy is very important. If the patient says, I want that, we can't do anything for that. But properly, everything is explained and still they go, it happens. See, I know my own friend, her uncle was not well, and I know very well it's not going to happen anything if they take him for the chemotherapy also. You won't believe they spent 10 lakhs for him. Okay. And finally he went off. And after that, they realized, they said, oh my God, that ma'am told also, but still we took her. So that was after realization. Okay. So in some things, this happens. So we have to cross our fingers. Rare cases. Michael David had said, very, very truly said that not only in your place, all over the world, we need more training so that palliative care is established all over the world, in every nook and corner of the globe. Okay, so that for that training is very important. And when we talk about training, it's for the healthcare providers. Right from the day they step into their institution, they need a training. So that right from the first year, they will come to know what is palliative care. And by the time they pass out, they become doctors or nurses or whatever it is. Okay, and they will carry this palliative care throughout their life. So again and again, training is very important, and already who have finished their studies and everything, they too need the training. And like this training only will help you all. Dr. Sridevi, can
we can start the case presentation. Yes.
Yeah, sure.
So as mentioned in the beginning, today we'll be doing from our side as a model case presentation. So next week onward, we are expecting patient stories from your side. So you can bring up the patients that you see and that you feel that needs to be discussed in this forum.
Good afternoon to all. I am Reshma Srikumar, working as a session head in home care nursing services at Palliative, India. Now I am going to present a patient story of 39-year-old male, diagnosis with rheumatic quadriparesis with stage 4 pressure sore on sacral region and left gluteal region. And the presenting complaints are patient complaints of constipation 2 days. He is having bed sore over the sacral region and the gluteal region. Complaints of moderate pain over the hip region and urinary leakage. History of presenting illness. He had history of fall while carrying weight followed by neck pain and weakness of both limbs and was diagnosed with traumatic quadriparesis in August 2015. And he got admitted in an Ayurvedic hospital and got discharged from there after 1 month. After 6 months, he developed a bed sore over the sacral and gluteal region. It was stage 4. History of he is having history of pain over the hip and wound site for more than 2 weeks. And pain over the hip region bilaterally. The pain score was 5/10. Pain is intermittent in nature and burning type of pain he is complaining. And wound site. In the wound site also he is having pain. The score was 4/10, continuous in nature and throbbing type of pain. Due to this, sometimes they keep the wound open. The sleep was disturbed and the oral intake is also decreased. In physical examination, patient was conscious and oriented, temperature 98°F, pulse 82 beats per minute, respiration 20 breaths per minute, BP 120/70 mm of Hg, and all other systems are within normal limit. And about the pressure source, warmth and tenderness present over the pressure source, exudates present, tunneling present, and shape is irregular, foul smelling. And next is about the treatment and significant investigations. Routine investigations done at the time of admission and all parameters are within normal limit. And next is about the psychosocial aspects. 39-year-old unmarried man living with his 65-year-old mother in a rented house. He has one sibling and he is married and living separately and not caring and helping them. He was a manual laborer and was the breadwinner of his family. Now, his mother is a manual laborer and she is taking care of him. Now, the main source of income is from mother's daily wages, her pension, and some of his friends, and have taken rupees 1.5 lakh from private finance bank for the treatment purposes. They are devout Christians, now unable to go to church. This makes him very sad. He communicates through cell phones. And he says to his mother, like, I don't think I can walk, so please don't spend money over my treatment. And the main concerns are pressure sore, pain, and the financial problems. Summary, 39-year-old man with traumatic quadriparesis with bed sores present over sacral and gluteal region with pain over his hip region. Pressure sores are stage 4. And the discussion points are, do we need to provide palliative care for this patient? And what are the problems faced by this patient? At last, what all can be done for this patient and his mother?
Thank you, Reshma. So we'll start hearing from the participants first. So you have heard Sister Stella talking about who needs palliative care, what is palliative care, when should we start, everything about it. So do you think this patient needs palliative care? And we would like to hear from you, like what all can be done for this patient. So we'll wait for your responses. You can either unmute yourselves or you can type it in the chat.
Yes, the patient needs palliative care. Needs palliative care.
Yes.
Yeah. Yeah, pain control, psychological support.
Sister, you have raised your hand. Would you like
Yeah,
to talk? I think it's Sister Velangani. No, sister, we can't hear you. Can you press on the mute but the mic button? Yes, now you can speak.
We need to give psychological support for the patient as well as the mother, for his mother. And we need to give him palliative care, encourage him to come to the palliative centers and all.
Yeah, most of them have covered a lot of things. Almost most of the things have been covered. What sister was saying, like palliative care, they need to come. My question is to you, sister, do you think that the patient family will be able to come to you in the palliative care?
I mean, we have to, if we come to know that they are a registered patient, encourage them through the people, or we have to go to them to give the care. That is the.
So that's very right. Okay. See, the condition of the here, mother is the only carer. Okay. And she's quite old. See, 65 years old, that lady, it's not possible for her to bring her son to the hospital. And if at all she wants to bring also, okay, she has to hire an ambulance or a car, something like that. Okay. And the distance from her place to the palliative care, where it is, that is the second. Okay. And all alone, I don't think she will be able to do all these things. Okay. She has to, financial already there is a problem. How they are going to face that problems? Okay. So the best thing is we do a home care for the patient. Yeah, if there is a palliative care department is there, one inpatient department is there, at least the palliative care people, I mean group, the team can go get the patient back to the hospital, I mean the palliative care, admit, teach them about the rest of the things, whatever it is, like you people said pressures or pressure ulcers, this one, what's the dressing and everything. We can teach them the care of the patient, basic care, what to do, and then we can discharge the patient. So home care is very essential for this patient. So what are the problems face this patient? You people have said, because why the patient needs to provide. What all can be done for this patient in this mother? We can't hear you.
Counseling.
Yeah, we can give the psychological support.
Yeah, yes, Harita. Yeah, psychological support, very important. Yeah. And what about the social support?
That is also there now.
So social support is a very, not only psychological support, social support is very important for this patient and the family. Okay. So any other thing you can do? Suppose the patient is in your place, you think. Okay.
We can educate them about palliative care.
Only about palliative care? Anything else?
Yes, it mentioned that the patient is a Christian and he isn't able to attend church and is very sad about that. So I think arranging for spiritual support, maybe a pastor could come and pray with the patient, or church members could come and provide community and spiritual support.
Yeah, very right, Sarah. Very right. We can do that. And nowadays, as you say, he's using the mobile phone also. Cell phone is there. And if the cell phone is a very good, I mean, on smartphone, he can have the mass or something. He can have that video also. Thank you. So, and one more thing, what all can be done for this patient, his mother? It's not only giving training to the patient and the family. Okay. Yeah, Elijah has said online church sessions, very right. Okay, so it's not only giving training to how to look after that patient. Okay, and one side we have to build up also her, because what is going to happen ahead slowly and slowly, we have to anticipate. See, he has a pressure ulcer, 4th stage pressure ulcer. Okay, and in fact, if the patient is looked after properly, okay, pressure ulcer can be healed also. Okay, you people know what are the stages of pressure ulcer, how we can cure the pressure ulcer, right? Okay, so if we focus on to that, like relieving the pressure of the patient, giving food, I mean good nutrition, and relieve the and good dressing, maybe we can cure his pressure ulcer. That is one thing. The second thing, we don't know much of the detail. Reshma will be knowing whether the patient has gone for any rehabilitation. Okay, rehabilitation is very important in most of these type of patients, quadriplegia, quadriparesis, hemiplegia patients, stroke patients. Why? Many of these patients can come back to, they can start walking, at least with the help of a walker or a stick, they can walk. Okay, so rehabilitation is very important in this patient. So what all can be done for this patient? We can give rehabilitation to the patient also. Physiotherapy, whether it was given, because the patient was in a government hospital, I don't think patient must have got some physiotherapy. Okay. Second thing, proper care was not given. That is why the patient is having an ulcer, right? Okay. So if they give that support to the patient, maybe patient could have come out, because this has happened in 2015. That's what I saw in the, in the history. Okay. So 15, now you'd say it is more than 7 years, right? More than 7 years. Okay, so the patient is completely now bedridden. Okay, now our support is that further we have to prevent him from the pressure ulcers. Further prevention should be done. His pain has to be relieved. Okay, this is all you have people have said. So pain can be relieved, and a regular review follow-up of the nearby palliative care. Okay, proper equipment, very right. We need to explain how to take care of the patient in home once patient is recovering. Yeah, very right, Sujita. Yeah, so these are the things that we have to support. When I saw this, Sini had sent me this, what to say, this presentation. Okay, I just came and I just, so when I saw this itself, suddenly in my mind, you know what went, I want to just share that. I joined Indian Army. Okay, after joining, then I thought I will leave and come back. Okay, in Army, it's very difficult at times. Okay, so I thought I will leave my training. I won't join. It's better to come back and all. But slowly I started working also. Okay, you know, half of mind and all, I was working that time. Okay, and I met a boy of 23 years old. Okay, from Karnataka. He was admitted in our ward, in ortho ward, with quadriplegia. Okay. He never used to talk to anyone, always very sad, looking up on the ceiling. Okay. And I was in my first year that time. Okay. So we were given the, what is it, duty to give him sponge bath. Okay. So daily giving him sponge bath. And that time, indwelling catheter and all, we were not allowed to put. Okay. Only the patient used to be, when the patient when came from outside, it was an indwelling catheter. Okay. So when we saw the penis, it was full of ulcers. Okay. Fully formed, and it was a pain for him. So what we did, we removed that, and what we did, we kept a urinal. Okay. So in between, we used to go and see whether he has passed urine or not. Okay, like that also we used to say, because 2-3 days we had to keep him like that, because they had a lot of problems. Some days his bladder, because he was not knowing whether bladder was. So somebody used to test, then we has to put a simple catheter and remove the urine. Okay, so we were preventing him, means to cure his ulcer, we were looking after him. Slowly what happened was, I started talking to him, communicate with him, and I was very good in communication, and blah, 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 used to talk. So I used to talk to him, and slowly started responding to me. Actually, he was supposed to go for his, attend his sister's marriage. That time this has happened. Okay. Somebody, means it was a playing, all the, what's the friends, now they did like this, slap at the back, and here it has hit on the cervical area, and that's how we become a quadriplegia. Okay. In fact, my communication motivated him so much because we wanted to send him to a rehabilitation center, and Army has a very, very good rehabilitation center in Pune, Kirki. Okay. But he said no to that because he said, I'm not going to come back in my life. Okay. So daily communication with him to tell him that please go for that. Let us see if something can happen means let us see. Okay. And slowly what happened, he started responding to me. And he started taking food. That was another thing. He never used to take proper food also because we need to feed him. No? Okay. So we started feeding, me and my friend. We used to feed him. Then we used to give him a sponge bath. And slowly we started putting him in a wheelchair, band him nicely and take him outside to show the outside, the greenery and all. And finally agreed to go to Pune, to Kirki. Okay. And finally he was sent for the rehabilitation. Okay. You won't believe, after 1.5 years, okay, by the time I finished my second year, I'm just going to my third year, I'm waiting. Ma'am, one of the colonels, she told me someone has come to meet you. Okay, so when I went, I saw someone slowly walking and coming with this one stick. Okay, slowly, I mean slowly he's keeping one step, still that side, he had some problem. Okay. When he came near only, I'm not telling his name. I still remember, I'll never forget that patient's name. Okay, I saw him. I was so glad to see him. You won't believe. And to this day, I always felt, no, my God. And that is the turning point of my life. I thought I will never leave nursing. I will continue my nursing. And today, it's almost more than 35 years. I'm still here. And he motivated me. At least it was motivation for me, I should say, motivate that I should continue in this. And you know what he said when he came to him? See, my eyes is still, there are tears in my eyes when I'm talking about that. What he told me, he said, just because of you, today I'm standing here. I know I won't be able to do much, but I won't be dependent on someone. Once I go back, I won't be dependent on someone. At least I can do my own things, daily bath and these things. Okay. So when you meet patients, this one is whenever you see your patients, okay, talk to them. Communication is very important. Maybe after that, when you communicate, some people may feel to come out with their problems with you. They will talk to you, even if in palliative care also. It is very important. Communication is very important so that they can talk to you. They can come with their problems. Maybe you can help them in some way. Some way you can help. And that is a very big thing that you are doing to that patient and family. Very big thing. And of course, only this much. We need to explain how to take care of the patient in home. Yes, someone has said. Okay, so from my side, only this much. And anything Dr. Sridevi, Sini, or participant wants to add up, you can add. So, okay.
Thank you, Sister Stella, and the participants for your interaction also. Is there anything else that we missed from our side in managing this patient? Please tell us that we can, is there anything that we should have done for this patient? Something which we have not discussed today. I think, yes, we've covered that point in the chat. That Sister Sujita was telling, that how to take care of patients in home. That's the very, very important part, as Sister Stella mentioned in the beginning. Taking these patients to hospital is not something very easy. Even for us, going to hospital is whole day job for the caregiver, right? They have to take a leave so that they can come with us. So what if we are bedbound and the elderly mother taking him? So like many patients, most of you might have seen, they need help from the neighbors just to get out of the room. Call at least 4 or 5 people from neighborhood, call an ambulance, which will cost some money, and then transport them to hospital. So as I think someone mentioned right in the beginning, that if we know that there is a patient out there in the community, we should go there and provide care.
Elijah has raised his hand.
Yeah, it's about to call.
Is giving money and fundraising professional in palliative care. Of course, fundraising. Dr. Sridhi, you want to add, or I will tell something and then you can add.
Elijah, from my experience, yes, we do have fundraising department, but that need not be the case everywhere because we are a standalone unit which runs on charity. We need fundraising. But if you take a corporate hospital where they do palliative care, they don't need fundraising. Money is not, the patients will pay from their own pockets. Because me, Sister Stella, everyone is working closely with a charitable trust where we see around 70 to 80% of patients under poverty line. So that place we need fundraising, but it is not mandatory. It depends on which setting you work. But sometimes even when you are a corporate hospital, if you want to take care of some social element, definitely you need funds. For example, transport. Even if you are in a big hospital, sometimes you may come across patients who need some help from our side. So entirely depends on which setting you work. Sister Stella from...
And what you said, that's very right, because we all are dependent on charity. So we need fundraising because everything is given free to the patient, right from medication, home care, all the equipments, whatever we are giving, medicines, everything is given free of cost for the patient. So we need some fundraising. Now, talking about giving money, what you are talking, see, not in the way of money, like education support. If the children are there, we give them education support. Medicine we are giving of free. So instead of giving money, we are giving even food support also. That is another thing. A family who doesn't have minimum, even one meal also. People are there who doesn't have one meal to have. Okay, so we give them even food support also. So medicine support is there, food support is there, and this one, what to say then, other equipment support. Everything we do give to the patients and the family. It is not only for them, for the family also. So it's not like money we are giving, but the materials and other things we are providing them. And of course, some patients, if they are coming from ambulance and all, suppose we ask them to shift and all, and if they don't have the money to pay, that is also being paid. Because we know constantly that such patients who are very poor, who are coming from that area. But here, when we again we talk about palliative care in Kerala, many patients are being transported, sometimes in ambulance also free. And some the community-based organizations support the patient and the family to reach out to the hospital. That is also being done. So it is according to your area, Elijah. If in your area, this is, if you feel the patient needs support in other than giving money, if you can do in other way, that will be better.
Ma'am.
Yeah.
Ma'am, yes. in India, so many old age homes are so there now. So how it's differs from palliative care? I mean, so many old age people, they are also having so many health issues in that old age homes now. So is that is similar to this palliative care, or it's differs, ma'am?
See, it differs. So it differs in the sense, it is just like, if suppose in the geriatric, I like said old age home. I know one. If I say I know one old age home, where that in the old age home itself, who is caring the patient, they are all trained under palliative care.
Okay.
Okay.
Got it, ma'am.
They know. Now you understood. So they do the communication, they give the symptom management, everything is being done according to the palliative care things. Okay.
Okay.
So that's already given. So if you take the organization of the sisters, charity sisters and all, missionaries and all, okay, it is almost a small model of palliative care only, because they give every support to the patient. All support is given to the patient. Okay. But in some old age home, nothing except for that. If some problems are there, they are taken to the hospital, because some old age homes are like that, where nobody's to look after and they are dumped here. Like their children are gone abroad, so they have dumped the parents or whoever it is, they're into the old age home. Okay. Some old age home is like where they need not have any other problem. They can walk, they can do everything, but nobody to look after. Okay. There what happens is they can get their medications, everything they are getting, and they're jolly well for spending their life like that. Okay, so there are different types of models of geriatric care is there available. So each thing we have to go and find out how it is being run.
Okay. Okay, ma'am. Thank you, ma'am. Got it, ma'am.
Thank you, Sister Stella. If there are no other questions, maybe we can wind up today's session. Thank you all the participants for your questions, suggestions, and interactions. We hope to keep this up for the upcoming 18 more sessions. So please make it more interactive. Then only we will all learn. Otherwise, there is no point in someone coming and taking sessions. You should share your experience. You should ask questions. That way, every one of us can learn together in this. Thank you so much. Please start sending in your case presentations because our next session is on Thursday. So at least by today, maximum by tomorrow, we have to start getting the case presentations on the topics. So please start sending, as mentioned in the beginning, it is okay even if you are not seeing a palliative care patient, right? Now, Sister Stella mentioned what all patients can come under palliative care. How many patients that you see in pain in a ward. So you can take any of those patients' story and bring it up for discussion. Thank you so much, everyone. Have a nice evening. Sini.
And thank you all once again, Dr. Sridevi, Sini, and all the participants. Bye.
Thank you.
Bye, ma'am.
Thank you,
Thank
ma'am.
you, ma'am.
Participants, I have shared a feedback link in your chat box and in your WhatsApp group also. I'm requesting all to submit it without any delay. Thank you all. We'll be having our next session on Thursday, 17th. I will be notifying in your WhatsApp group also. Thank you all for joining us. Bye-bye.
Bye.